Welcome to the deep dive. Today, we're really getting into one of the most fundamental areas in medicine, I think. The real measurable link between our minds and our bodies.
It's absolutely core.
Yeah, and our mission here is to unpack consultation-liaison psychiatry. It's basically the ultimate deep dive into how psychological stuff and physical illness really talk to each other.
Right.
We should probably start with that term, psychosomatic medicine.
Right.
It comes from the Greek, psyche for soul or mind, and soma for body. Sounds integrated, right?
It was meant to be, but that word psychosomatic, it got a really bad reputation, frankly.
Yeah, people hear that and think,
They think, oh, the doctor's saying it's all in my head, that the pain isn't real, it's manufactured.
yeah,
And unfortunately, sometimes even other doctors kind of fell into that thinking.
which is exactly why the field needed a serious vocabulary update, something that reflects the actual science.
Absolutely. So now the term we use is Consultation-Liaison Psychiatry, or CL Psychiatry. And crucially, the official diagnosis changed too. In the DSM-5, we moved away from things like psychophysiological disorders.
Okay, so what's the term now?
It's psychological factors affecting other medical conditions. Sounds a bit clunky, maybe.
But it's more accurate.
Much more accurate, because it emphasizes the bidirectional influence. It's not just the mind causing disease, it's about how psychological factors could be stress, depression, anxiety, whatever, genuinely affect the course, the outcome, the treatment of pretty much any major physical illness.
Okay, that makes sense. It's an interaction, not a one-way street.
Exactly. And, this modern view didn't just pop up out of nowhere. If you look back, some of the earliest ideas trying to connect mind and body were, they were based on physical mechanisms that seem a bit strange now.
Okay, let's unpack some of that history. Like, what were some of those older ideas that kind of show how far we've come?
Well, back in the mid-19th century, there was this diagnosis called reflex neurosis, or sometimes spinal irritation. The idea was that irritation in one part of the body could sort of mechanically or reflexively trigger problems somewhere else through the nerves.
A mechanical reflex.
Yeah.
Okay, how did that play out? Like, an example.
Sure. So the famous neurologist Moritz Romberg, he actually argued that issues with the uterus could cause hysteria in women.
Wow.
Yeah, he thought irritation in the reproductive organs led directly to things we'd now see as emotional or neurological symptoms, maybe seizures or that feeling of a lump in the throat, globus hystericus. It just shows how, before we really understood the brain, they focused on the physical connections they could sort of see or imagine.
Right. Sounds incredibly dated now, but you can see they were trying to find some physical link. Then fast forward to the 20th century, and the focus really shifts, doesn't it? Away from just nerves and organs to actual psychological processes.
It does. Big shift. That's when we start getting concepts that are, still foundational for CL psychiatry today. Well, in the 1920s, you get Wilhelm Stekel coining the term somatization. That's the idea that psychological distress gets experienced and communicated through physical symptoms.
Okay.
Then a bit later, Helen Flanders Dunbar, around 1936, she proposed this idea of specific personality types being linked to specific physical illnesses, kind of like the later type A personality idea for heart disease.
Ah, right. That specific personality traits might make you more vulnerable to certain conditions.
Exactly. And then there's alexithymia. This is a really interesting one, developed more by Sifnios and Nemaya in the 70s.
What's the core idea there?
It suggests some people have, maybe through development, a real difficulty identifying and expressing emotions, especially complex ones related to conflict.
So they can't put feelings into words easily.
Pretty much. And the theory goes, if you can't process or articulate that emotional energy, it has to go somewhere. The mind can't speak the emotion, so the body sort of acts it out through physical symptoms. It provides a potential mechanism for somatization.
That's fascinating. And all this historical groundwork kind of leads up to a really crucial framework, doesn't it? The biopsychosocial model from George Engel.
Yes, 1977. Engel's model was revolutionary. It brought together the biological side, the central nervous system, the autonomic nervous system, the HPA stress axis with the psychological and the social factors.
Why was that such a big deal?
Because it forced medicine to move beyond just looking at the body as a machine separate from the mind and the person's life. Engel insisted we have to see the whole picture, bio, psycho, social, all interwoven, influencing health and illness. It's really the philosophical backbone of CL psychiatry.
Okay, so with that framework in mind, Let's apply it. Where do we see these connections most clearly? Let's start with the heart, the cardiovascular system. The link between depression and coronary artery disease, CAD, seems massive.
Oh, it is. It's one of the strongest, most consistently found links in this whole field. And it's crucial to understand depression isn't just feeling sad because you got a scary diagnosis. It's an independent risk factor. Having depression nearly doubles your risk of developing CAD in the first place. And if you already have CAD, being depressed roughly doubles your risk of bad outcomes like another heart attack or even death.
Doubles the risk. That's
Right.
huge.
Yeah.
How does depression actually damage the heart physically?
Well, the sources point to two main routes. First, there are the behavioral pathways. These are kind of the more obvious ones.
Like smoking.
Exactly. Depressed individuals often have higher rates of smoking. They tend to be more socially isolated, less physically active, and this is critical. They often struggle with sticking to their medical treatments, taking their meds, following doctors' advice.
Okay, that makes sense. And the second pathway.
That's the biologic pathway. This is the stuff happening inside. Depression is linked to significant autonomic nervous system dysfunction. Basically, your sympathetic nervous system, the fight or flight response, gets stuck in the on position.
So you're constantly revved up.
Right. And that constant state increases heart rate, raises blood pressure, promotes inflammation, and generally contributes to wearing down the blood vessels over time. It's chronic wear and tear.
Okay, the constant stress response. Makes sense. Now, moving from the heart, let's talk about the gut. The GI system is famously sensitive to stress, right?
Oh, definitely. And a big focus here is on what are called functional GI disorders, or FGIDs. Think irritable bowel syndrome, IBS, as the classic example.
And what defines an FGID?
The key thing is they involve chronic or recurring gut symptoms, pain, bloating, changes in bowel habits, but there's no identifiable structural damage or biochemical problem that explains them. Scopes look normal, blood tests are fine.
But the symptoms are very real.
Very real and incredibly common. The source mentions that over a third of new patients going to specialist GI clinics actually have an FGID.
Wow, over a third.
Yeah, and the psychiatric overlap is huge. More than half of people with IBS also have a major psychiatric condition. Depression, anxiety, PTSD are really common.
Which brings us right to the gut-brain axis. We hear that term a lot now.
We do. It perfectly captures that two-way street we talked about earlier. It's a constant communication loop between the gut and the central nervous system.
We usually think about stress in the brain affecting the gut, but does it work the other way too? Can the gut send signals up that affect mood?
Absolutely. Your gut has this huge network of nerves, sometimes called the second brain. If things are off down there, maybe chronic inflammation, changes in the gut microbiome, effects from a past infection, those distress signals travel up, often via the vagus nerve, right to the brain.
And that affects.
It can alter neurotransmitter levels, change hormonal balances. The message isn't just gut pain, it's more like a systemic something's wrong signal, which can absolutely manifest as increased anxiety or changes in mood. It's a complete feedback loop.
So if the problem is so interconnected, how do you approach treatment for something like IBS?
You really need a multi-pronged approach. Yes, sometimes psychotropic medications can help manage symptoms, but psychotherapies are often vital.
Like CBT.
Exactly. Cognitive behavioral therapy, CBT, is really key. It helps patients identify those unhelpful thought patterns about their symptoms, understand the mind-body connection, and develop coping strategies to feel more in control. Interpersonal therapy, IPT, can also be very effective, focusing on relationship stressors that might be contributing.
Okay, from the gut. Let's shift to the most visible organ, the skin. Psychodermatology. This feels like a really complex area, especially because skin conditions are right there for everyone to see, which can cause a lot of stigma.
It's hugely complex, and the visibility factor adds a whole layer of psychological burden. To make sense of it, the KU classification is really helpful. It basically groups these skin-mind connections into three main types, depending on what's driving what.
Okay, break those down for us. What's the first type?
First, you have psychophysiologic disorders. These are real diagnosed skin diseases, think psoriasis, eczema, atopic dermatitis, that are known to be significantly worsened or flared up by psychological stress. The skin condition is primary, but stress pours fuel on the fire.
Got it. Stress makes a real skin condition worse. What's second?
Second is secondary psychiatric disorders.
Hmm.
Here, the psychological problem like anxiety or depression develops as a result of having a disfiguring or distressing skin condition. So someone with severe acne or maybe vitiligo might develop social anxiety or clinical depression because of the impact the skin condition has on their life and self-image. The skin problem comes first, causing the psychological distress.
Okay, that makes sense too. And the third type, this sounds like maybe the trickiest one.
It often is. The third group is primary psychiatric disorders. In these cases, the actual skin lesions you see are self-induced. They're caused by the patient's own actions, driven by an underlying significant psychiatric issue, even though the patient might not recognize or admit they're doing it.
Okay, that sounds challenging. Can you give us a really clear example of a primary psychiatric disorder affecting the skin?
The classic and probably most memorable one mentioned is delusional parasitosis, or DP.
Delusional parasitosis.
Yes. It involves a fixed, unshakable belief, a delusion that one's skin is infested with parasites, bugs, worms, something crawling. The person is absolutely convinced this is a dermatological problem,
Even when there's no evidence.
even with zero objective evidence. And there's a characteristic sign doctors look for.
What's that?
It's called the matchbox sign. Patients will often bring in little containers, matchboxes, plastic bags, jars filled with samples of what they believe are the parasites. Usually it's just bits of skin, lint, scabs, dust.
The proof.
Exactly. Seeing that sign is a huge clue that the underlying issue is psychiatric, not dermatological. And the treatment isn't creams or lotions. It often involves medications like SSRIs, which are also used for things like body dysmorphic disorder involving the skin, or sometimes antipsychotics to target the delusion itself.
Wow. Okay, so that really highlights the complexity.
Yeah.
And all of this, the heart, the gut, the skin, it seems to circle back to one core concept, right? Stress.
Absolutely. Stress is the common thread. And our modern understanding really builds on Hansel's work back in the 1940s. His concept of the general adaptation syndrome showed that the body has this predictable physiological way of responding to any kind of stressor involving hormones from the adrenal cortex.
And there's a whole field dedicated to studying exactly how stress impacts our immune system, isn't there?
Yes, that's psychoneuroimmunology, or PNI. It sounds complicated, but the core idea is simple. The brain, our behavior, and our immune system are constantly talking to each other. It's a two-way street.
Okay, so PNI. How does stress actually affect immunity? Is it always bad?
Not necessarily. It depends on the type of stress. We need to distinguish between acute and chronic stress.
Right. What's the difference in terms of the immune response?
Acute stress, like, narrowly avoiding a car accident or facing a tight deadline, causes really rapid temporary changes. It's driven mostly by that sympathetic nervous system activation we talked about. Immune cells actually move around quickly, getting ready for potential injury or infection. It can be adaptive in the short term.
Okay, a quick mobilization.
Exactly. But chronic stress, the kind that goes on, like being a long-term caregiver, dealing with poverty, or grieving a loss that's different, it's generally associated with a decrease in certain types of cellular immunity, but also, paradoxically, an increase in inflammation markers, like pro-inflammatory cytokines.
So chronic stress dampens some immune responses, but ramps up inflammation.
That's the general picture, yes.
Yeah.
It's like the body's inflammation off switch gets faulty, and that persistent low-grade inflammation is thought to be a key link between chronic stress and a whole range of diseases, especially those associated with aging.
That really ties so much together, from those early historical ideas to the specific organ systems and the underlying biology of stress. We've covered a lot. The evolution from psychosomatic to CL psychiatry, the heart-depression link, the gut-brain axis, the Kukal classification for skin.
It's a journey showing how we've come to appreciate the body and mind as truly inseparable. And maybe a final thought to leave listeners with, something that really underscores this integration. Think about the relationship between diabetes, depression, and obesity.
Right, that's a trio we see together all the time in healthcare. Why is that connection so strong?
Well, the source material suggests it's not just coincidence. There seems to be shared biology underneath. Studies indicate shared genetic risks. Apparently, up to 12% of the genetic variations linked to obesity risk are also linked to depression risk.
Wow, shared genes.
Shared genes, and also common biological pathways, things like the HPA stress axis we mentioned, serotonin systems, and those inflammatory pathways. They seem to be involved in regulating mood, metabolism, and appetite. So these three conditions might actually travel together because they share fundamental roots.
Which has huge implications for treatment, doesn't it?
Exactly. It suggests that effectively treating the depression or managing the chronic stress might actually help improve the physical aspects of the diabetes or obesity, and managing the physical illness better might alleviate some of the psychological burden. It really reinforces the whole point of CL psychiatry. You have to look at the whole person, the integrated system, because the mind is fundamentally part of the medical equation.
A really powerful takeaway. We absolutely have to see the whole picture. Thank you so much for walking us through this crucial area of medicine.
My pleasure. It's fascinating stuff.